Welcome back, focused learners. Today, we are tackling an absolute giant. We're going to dive deep into Chapter 57 of Rangan Pharmacology, and we are going to master it in extreme detail, literally the whole shebang. Our goal today? To meticulously break down the pharmacological arsenal we use to fight cancer. We're talking drug classes, precise mechanisms of action, clinical uses, and, of course, those crucial adverse effects you absolutely need to know. And because medicine literally never stops moving, we're going to cap it all off by bridging your textbook knowledge with the most cutting-edge 2025 and 2026 oncology approvals. So grab a coffee and get ready to take some serious mental notes. Okay, let's dive into this, because right here is the fundamental physiological challenge of cancer treatment. Think about it. When we treat a bacterial infection, we're exploiting the fact that bugs have vastly different cellular machinery than we do. But cancer? Well, cancer cells are alarmingly similar to normal human cells. They're basically our own biology, just gone completely rogue. So the million-dollar question is, how do you poison the disease without poisoning the host? And that, my friends, brings us to the actual definition of chemotherapy. Now, originally, this term just meant using drugs that were selectively toxic to any pathogen. But today, we use it almost exclusively to refer to treating tumors. Because cancer cells lack those major, glaring biochemical differences from our normal cells, conventional cytotoxic chemotherapy has to rely on what we call a painfully small margin of selectivity. Basically, they attack all cells, but we just kind of cross our fingers and hope they damage the fast-growing tumor cells just a little bit more than our healthy tissue. Honestly, that razor-thin margin of selectivity is exactly why we see such devastating side effects. In fact, the textbook includes this incredibly dark footnote from a practitioner. It says, "To be an oncologist, one has to hate cancer more than one loves life." Wow, right? It's a really stark reminder that a lot of the drugs we're about to cover are, by their very nature, incredibly potent toxins. They cause distressing unwanted effects. We're talking severe nausea, hair loss, bone marrow depression, even sterility, all because they are actively destroying our normal, rapidly dividing cells right alongside the malignant ones. So here's our agenda for this explainer. First, the pathogenesis of cancer. Second, alkylating agents and cytotoxics. Third, antimetabolites and plant derivatives. Fourth, targeted biopharmaceuticals. And finally, those exciting 2025 and 2026 oncology approvals. Let's get to it. Part 1. The pathogenesis of cancer. We really need to understand the target here. So cancer cells manifest a few very distinct characteristics. First off, they suffer genetic lesions. This means their tumor suppressor genes are completely inactivated, while oncogenes get activated. And what does that do? It leads to uncontrolled proliferation, which is often supported by tumor-related angiogenesis, basically the tumor building its own new blood vessels just to feed itself. They also lose their normal cellular function through dedifferentiation, and they gain this really deadly ability to invade local tissues and metastasize to distant organs. Now, the absolutely crucial takeaway here is that most of the drugs we're going to discuss specifically target that very first characteristic, uncontrolled proliferation. Because they attack dividing cells, well, your normal rapidly dividing cells like your hair follicles, your GI tract lining, your bone marrow, they're unfortunately going to suffer a lot of collateral damage. Moving on to part 2, alkylating agents and cytotoxics. These are the heavy hitters. Now, what's really interesting here is the exact molecular target. Alkylating agents work via this highly reactive carbonium ion intermediate. Imagine it acting like superglue on a broken zipper. It forms these incredibly strong covalent bonds, most critically right at the highly nucleophilic N7 position of guanine. And because most of these agents are bifunctional, meaning they've got two reactive groups, they can actually cross-link two entirely different guanine bases on the DNA strands. This physical cross-linking completely jams up DNA replication. It causes defective chain replication, actual strand breakage, and ultimately, it triggers cellular apoptosis. The cell just self-destructs. Let's break down some specific classes. Notice the nitrogen mustards at the top. These historically evolved from World War I mustard gas, believe it or not. Drugs like cyclophosphamide and bendamustine are totally foundational. Then we have the platinum compounds, like cisplatin and carboplatin, which are really infamous for their extreme nausea profiles. I also want you to specifically note busulfan down at the bottom. It has this very unique, highly selective depressive effect on bone marrow, which makes it incredibly useful for chronic granulocytic leukemia.
But across the board, these drugs depress bone marrow function, they cause hair loss, and this is key. They carry a real risk of causing secondary leukemias down the line just because of the sheer amount of intense DNA damage they inflict.
Next up, we've got the cytotoxic antibiotics, which also attack DNA directly. Doxorubicin is a massive one you need to remember. It inhibits topoisomerase 2, which is a DNA gyrase, and completely blocks replication. But its critical test prep side effect? Dose-related cardiotoxicity. You have to watch the heart. Then look at bleomycin. This one is clinically fascinating because it actually fragments DNA chains and acts on non-dividing cells. But the craziest part? It causes virtually no myelosuppression, none. Instead, its major limiting toxicity is pulmonary fibrosis. So, golden rule here. Always link bleomycin to the lungs and doxorubicin to the heart. Got it?
All right, part 3, anti-metabolites and plant derivatives. This is where we start subverting the actual cell building process.
So the crucial point is that anti-metabolites basically trick the cancer cell. They sneak into the cell and act as totally fraudulent building blocks during DNA synthesis. Methotrexate is your classic folate antagonist. It inhibits the enzyme dihydrofolate reductase, literally starving the cell of the tetrahydrofolate it desperately needs for DNA synthesis. Then we have pyrimidine analogs like fluorouracil, which inhibits thymidylate synthesis, and purine analogs like mercaptopurine. Because they all subvert the DNA creation process, they are all extremely potent myelosuppressives. They hit the bone marrow really hard.
Now, how do the plant-derived drugs work? Well, they target the cell's physical scaffolding, specifically the microtubules that are absolutely necessary for pulling DNA apart during mitosis. But here's the wild part. They do it from completely opposite directions. Vinca alkaloids bind to tubulin to prevent the assembly of the microtubules altogether, arresting the cell right at metaphase. Taxanes, on the other hand, stabilize the microtubules. They essentially freeze them in a polymerized state so the cell can't complete division. Either way, both mechanisms utterly destroy the cell cycle. The side effect profiles for these plant derivatives are super specific, so pay attention here. Under vinca alkaloids, vincristine is famously neurotoxic, causing sensory changes and weakness, but it actually has very mild myelosuppressive activity compared to the rest of the pack. Taxanes, like paclitaxel, which is often used for ovarian cancer, carry a really high risk of severe hypersensitivity reactions and fluid retention. And please don't forget the camptothecins, like irinotecan. Remember how we said doxorubicin inhibits topoisomerase 2? Well, irinotecan specifically targets and inhibits topoisomerase 1. That's a classic distinction you'll want to remember. Let's move to part 4 and see how this builds into targeted biopharmaceuticals. We are stepping into the era of precision engineering. Instead of just blindly attacking every dividing cell in the body, biopharmaceuticals, which are often monoclonal antibodies or small molecule kinase inhibitors, target specific defective cellular controls. For example, bevacizumab physically neutralizes VEGF, effectively choking off the tumor's ability to undergo angiogenesis. No new blood vessels, no food. Trastuzumab specifically hunts down oncogenic HER2 receptors, which are heavily utilized in certain breast cancers. Erlotinib blocks epidermal growth factor receptor tyrosine kinases. And imatinib, that is a legendary drug that inhibits the specific BCR/ABL kinase signaling pathway. Basically, we're now at a point where we use the unique genomic profile of the tumor itself to dictate the exact biopharmaceutical weapon we deploy. It's like using a sniper rifle instead of a shotgun. And that brings us to Part 5, 2025 and 2026 oncology approvals, the cutting edge of hyperspecific therapy. The overarching theme of all these brand new approvals is just absolute hyperspecificity. Look at vepdegestrant, targeting highly specific mutated advanced breast cancers, or zolbetuximab, a targeted therapy for very specific GI and esophageal cancers. But the absolute standout on this list is datopotamab deruxtecan. This is an ADC, an antibody-drug conjugate. It literally combines the homing missile precision of a targeted antibody with the lethal payload of a conventional cytotoxic drug. It delivers the poison directly inside the EGFR-positive non-small cell lung cancer cells, while totally sparing normal healthy tissue. It's basically the ultimate evolution of selective toxicity. And this brilliantly illustrates our next point, the number 7. Just recently, an injectable treatment called Tecentriq SC was approved that reduces a complex targeted lung cancer treatment down to a simple 7-minute subcutaneous injection. 7 minutes. We are actively replacing agonizing, hours-long intravenous drips with these hyper-efficient delivery systems. It's a total game changer for patients. It is honestly incredible to think about the journey we've just taken in this explainer.
I mean, we started with conventional mustards and alkylating agents that just indiscriminately tear apart the DNA of every single dividing cell in your body. And today we're armed with genomically guided antibody-drug conjugates and rapid 7-minute injections. It really forces us to ask, as we continue to refine this targeted precision, are we finally on the precipice of turning cancer from a terminal, terrifying diagnosis into a long-term, manageable chronic condition? I'm going to leave you with that thought. Keep reviewing those tables, master those drug mechanisms, and I'll catch you in the next explainer.